Good day. I'm Dr. Ben Anderson from the Breast Health Global Initiative based at the Fred Hutchinson Cancer Research Center. Today's seminar is for CUGH, jointly sponsored by BHGI, is Improving Breast Healthcare Through Resource Stratified Phased Implementation. My colleagues, Dr. Ophira Ginsberg and Dr. Alex Enyu, will be joining me in this presentation. We will be ending with a question and answer session and look forward to your engagement. Breast Health Global Initiative was jointly initiated by the Fred Hutchinson Cancer Research Center and Susan G. Komen for the Cure, with support from the UW-Medicine School of Medicine and the Seattle Cancer Care Alliance. These are the sponsors for the Breast Health Global Initiative 2018 Global Summit, who provided unrestricted educational grants to make this possible. In 2018, the Breast Health Global Initiative held a global summit that permitted the analysis of phased implementation. This cancer supplement was just published in May, and it is the summary of the work of the BHGI. Within this supplement, which is available at no cost for downloading, are 4 consensus statements: an overview, a statement on health system strengthening, a statement on treatment, and a statement on early detection, each of which are focused from a phased implementation standpoint that we will be talking about later. In addition, there are 10 individual manuscripts that address specific pointed topics for this. Breast cancer is the most common cancer among women around the world and in the United States. It is not the leading cause of cancer-related deaths, but a close number 2 after lung cancer. We know that we're making improvements in breast cancer outcomes. In the United States, we started screening in the early 1980s, and it was approximately 8 years later that we started to see a drop in breast cancer mortality. So there are these tremendous opportunities for improvement. We have had a drop in breast cancer mortality in the US by 35% since that time. However, this has not been true in all groups. There are underserved communities, such as the African American community, where the outcomes in breast cancer have lagged behind. We are having improvements among people of color, but it has been dragging, and this clearly has to do with healthcare systems. 1/3 of these differences are explainable by access to healthcare and insurance. This is a very timely question. Earlier this month, Dr. Sharpless from NCI published this editorial in which it shows the excess deaths anticipated from the COVID-19 pandemic in the US for both breast and colorectal cancers. We have to think through how to manage breast cancer and other cancers in limited resource environments. In order to make improvements, we have to begin by understanding the systems that are necessary. And this diagram is actually a universal diagram for how breast cancer is managed. And it is the same whether one is in Seattle, Washington, or in Kumasi, Ghana. There are 3 phases to this strategy. There's the patient interval, where the patient initially presents either with symptoms or through screening. There is a diagnostic interval in which we either prove that it is cancer or prove that it is benign. And then there is a treatment interval in which this takes place, where we either provide curative therapy with curative intent or palliative care for those with such advanced stage disease that we are not able to improve on outcome. In phased implementation, the question is, how can we implement with existing resources strategies that will improve these outcomes, and how can we measure those stepwise improvements in meaningful ways? I would like to turn over the presentation to Dr. Ophira Ginsberg, who was the chair of the early diagnosis panel and will be talking to us about the outcomes of that discussion. Dr. Ginsberg. Dr. Ginsberg, I think you're muted.
My apologies. I thought I unmuted. Thank you. Thanks, Dr. Anderson. I'm going to present what is one of the papers in this series, specifically on a phased approach to implementing breast cancer early detection. And some of this will be familiar because you've just seen the diagram that Dr. Anderson showed, we're going to focus here between the patient interval and the diagnostic interval in terms of how a woman presents and what happens next. It's incredibly important to pay attention to the way that we're framing things here. So I'm not going to get into a discussion really about which type of screening modality is better, if you're having population-based screening, for example, but just the core elements of what we're working with and what might be relevant in terms of how to start and how to ultimately implement an effective program of breast early detection to reduce mortality. So here we say in the first paper, you'll see this towards the end, but I'm going to start with this. The implementation phases for early diagnosis and detection pathways. I'm not going to go through the whole thing, but just to show you here, on this axis is the program interventions, which include early diagnosis, and I will describe this in a moment, early diagnosis with targeted screening, ultimately with organized screening. So even though a lot of the focus is on how to build capacity for the diagnostic part, getting women to the right approach to diagnosis, we are still thinking of how to also build in these phases to be able to achieve ultimately population-based screening to reduce mortality in many settings. So first, with clinically detectable disease, there's a lot of good guidance that we include in the paper that will be familiar to some people. WHO has the Guide to Early Cancer Early Diagnosis, the WHO position paper on mammographic screening from 2014, and a couple of years later is the IARC handbook on breast screening that goes beyond this to also discuss the latest evidence at that time on the different modalities, which is beyond the scope of this talk. The main points here are that early diagnosis for cancer increases the chance for successful treatment by focusing on detecting symptomatic patients as early as possible. And as probably seems obvious, but definitely worth stating, that promoting the early identification of cancer without appropriate access to treatment, without equitable access to treatment, is not only ineffective, but it's unethical. And the establishment of successful and systemic management of clinically palpable disease really has to be in place before to embark upon any kind of large-scale screening effort. The common barriers to early diagnosis, just to touch upon these in a few minutes, but there's more detail in the paper, is that when we start with awareness and accessing care, we need to think about what the potential barriers are and to study these in each setting. This is a role of implementation research, of course, which is also covered well in specific papers and throughout the entire special supplement in cancer from the BHGI Summit. Some of the barriers here include, for example, not exhaustively, poor health literacy, cancer stigma, limited access to primary care being absolutely essential in this process. The clinical evaluation for diagnosis and staging, which I'll mention again in a moment. Let's think about what the barriers might be: inaccurate clinical assessment and other delays in the evaluation. I wanted to mention this here because often we are told, remember, it's not about when a woman presents. Presentation may be prompt, but diagnosis may be delayed. And that's often a barrier at this stage in the diagnostic pathway. Access to treatment, of course, that will be the topic of the next speaker, Dr. Enya will cover. This is just to show from one slide in the WHO Guide to Cancer Early Diagnosis, the potential interventions to overcome such barriers. For example, when we talked about stigma and other issues in the community, empowerment and engaging people, community-based participatory research, again, is part of this implementation research. Ultimately, we need to help the community members understand what breast health is and when to seek care. Interventions here can include improving capacity at the first contact point, which might be primary care or secondary care, depending on an individual health system. Going to management of imaging detected disease and ultimately population-based screening, just kind of motherhood and apple pie basic stuff here. You start with the whole population. You start with the targeted population within the whole population. Age X to Y, for example. Individually invited women, population-based screening requires invitations. It's programmatic. Then when you look at how much smaller the circles are getting, when you have how many women ultimately come who are screened, how many who are screened who are positive, and how many women ultimately have a diagnosis of breast cancer, you can get a sense of how much is required in terms of system requirements, not just financially, but otherwise to make sure this program can actually reduce mortality. And not to belabor the point, but I would suggest we can go back to that perhaps in the Q&A of what are those system requirements. And some of the case examples I'll show cover this. How do you know what you have? What do we have? And what do we need in a given setting, in a given country? We present the situational analysis concept from the BCI 2.5 toolkit that was developed by the BHGI, the Breast Health Global Initiative. This is a collaborative effort in order to help countries assess what they have by facility assessments, by questionnaires, by surveys, etc. And these have been used in a number of countries now to quite a bit of success to be able to show what the gaps are in more detail and then to target those gaps with the government's program. There was one case in the paper from Appalachia, USA, one from China, Mexico, Panama, and Tanzania. We don't have time to go into all of these, of course, in this short webinar, but just to make one point from each of these. In Appalachian, Ohio, which is a medically very underserved population, there was a breast cancer early detection program with mammography, as is the case in the US for population-based screening, and they added a very effective patient navigation program. They had already done this successfully in cervical cancer, and this was their first attempt doing this in breast cancer as well. And so far, they've had 4 early stage breast cancers of 6 women who were diagnosed from 70 who were able to be followed through the diagnostic pathway. The important thing here is that of 952 women who got a mammogram, 73 had an abnormality, and 70 of those 73 were followed through the care pathway to diagnosis. That is something that is essential in order to really achieve any kind of survival benefit or mortality reduction from breast cancer early detection. In China, the Eastern Michigan University Center for Health Disparities looked at 6 provinces and trained 2,000 survivors as cancer ambassadors. And they also trained 800 care providers, supported by multiple stakeholders. So this is the kind of effort that we hope will be, have positive findings. The results aren't yet available, but there's much more detail in the paper to look to that example with a very different setting. In Mexico, despite concerted efforts of the government, civil society, there were challenges identified in early detection for mammography because of the lack of organization and coordination. So even if you have something very effective in an urban setting, perhaps near a tertiary facility or within it, in a given country, it may be incredibly challenging to be able to scale that intervention. This is the kind of case study that we need to look at. Then in Panama, similarly, they found the same thing, but they were able to identify specific delays at every step in the diagnostic pathway that they now can target to find solutions to decrease those gaps. Again, that's a role for implementation research. Lastly, Tanzania actually used the BCI 2.5 toolkit to develop recommendations. There's also Brazil country breast healthcare assessments also available online with the BCI 2.5 tab that we can show you. Tanzania was able to actually effectively do the situational analysis with the government support, and then held a multi-sectoral stakeholder summit over several days that directly was able to use this product to inform their ultimate final version of their breast cancer early detection guidelines for the country. A couple of more slides only. I'm going to show you very briefly a sample of metrics to identify and track the outcomes that are highly relevant. When the rubber hits the road, what do you need to know? So for example, here at the top, we have community breast awareness. What is the percentage of the population that's aware of breast cancer symptoms? The percentage of the population that knows where to go for effective management? Provider awareness. Then we go down the list here. Among the patients with suspected breast cancer, how many days does it take from the first presentation at a health facility to diagnosis? And we can talk about the importance of that time frame with clinically relevant outcomes. Here you can see these are the resource levels from the Breast Health Global Initiative sort of framing, basic, core, and enhanced, etc., and what you need to be able to achieve the outcomes you're measuring, metric type, process outcomes, implementation outcomes, and then the clinical or health outcomes, and who's going to use the metric. We hope you find this very useful to look at as an example that you might find adaptable to your own setting. And a last comment, none of this is really going to be effective ultimately without considering financial constraints and better and sometimes innovative approaches to financing, also with good governance. We're lucky to have a member from the World Bank on the early detection paper that wrote a nice piece that describes the importance understanding catastrophic health expenditures that are associated with late-stage diagnosis, including non-medical costs that are often not considered. This can be up to 50% of total costs. Again, implementation, you need to think what you're doing, what the goal is, and how to get there. Ultimately, early-stage breast cancer is less expensive to treat. And I'll end there. Thank you very much. Next, we have Dr. Eniu.
Thank you very much, Ophira, and thank you, Dr. Anderson, for the invitation to participate in this webinar, where I will be talking on breast cancer treatment in low and middle income countries. And Dr. Anderson showed some statistics. I wanted just to remind everyone of us that we actually managed to paint the world in pink, and that actually breast cancer throughout the globe is it's number 1 in incidence. What is also very important that there will be an estimated 600,000 deaths worldwide in 2018. That was estimated by the global data. So we are dealing with a very important issue, and although I totally agree with improving early detection, I think that we have to be aware that in low and middle income countries, as I'm showing here, a lot of patients are metastatic at diagnosis. So the key point is that we indeed need to improve our capacity of dealing with patients if we want to be able to offer best care for our patients. Now, this audience may be aware of the fact that throughout the world there are many limitations when we discuss about what do we need to actually manage breast cancer patients. And we know there are areas in the world where there is one pathologist for more than 5 million people. We also know that 90% of the population in low and middle income countries are actually do not have access to radiation therapy. And we also know that actually only 5% of patients in low-income countries and 20% in middle-income countries have access to safe, affordable, and timely cancer surgery. Access to medicines is also a big issue, and it's not always related to the cost of those medicines. The WHO maintains, as you know, the essential medicines list, and we've shown that actually several essential, old and expensive medicines are in shortage throughout the world. And this is not always an issue of resources. So these are the limitations with which we have to work when trying to deal with the pandemic of breast cancers that we have seen in the first slide. Now, again, this audience should know that most health systems in low and middle income countries are ill-equipped to deal with the rising burden of cancer. There are shortages of qualified personnel. Access to drugs, as I've shown you, hinders the availability and quality of care. The referral systems are poorly developed, resulting in discontinuity of care, and information systems are very inadequate in many countries that do not have population-based cancer registries. So the financial part of this is that cancers are seriously underfunded, with governments struggling to actually scale up their response on NCDs, but are not able actually to allot enough resources, and actually the households bear a lot of the financial burden, which leads in many cases to personal bankruptcy. So this was the background when the Breast Health Global Initiative started to tackle the issue. And I guess this slide summarizes 2 key points that I am sure Dr. Anderson will further discuss with you during his presentation. I think when thinking about what we can do to improve the situation and treatment of breast cancer with limited resources, one important element that was proposed by the BHGI was the stratification of resources based on level of resources. So we know that all interventions provide benefit to the patients. However, there are interventions that provide important benefits in terms of survival, whereas others are just optional. And we've proposed this stratification scheme that you can see on the left side of the screen, and I'm not going to go into the detail. Using this stratification of resources and actually understanding that there are levels for which when resources are limited, one has to prioritize. We have analyzed the interventions available to treat breast cancer and tried through the use of a checklist to actually identify the strengths, the weaknesses, and also the resources that are needed for each of those interventions to be administered efficiently. And based on this kind of analysis, we were able to propose resource stratified guidelines that tried to actually make best use of what is available, to make best use of the interventions and allowing a incremental allocation of resources, therefore for a system to be able to go from the basic level to the maximal level by providing a stepwise incremental allocation system. So during the last discussions that we had through the BHGI, the treatment area was analyzed from the point of view of phase and implementation. And I'm focusing here on the treatment interval for which, as you know, multidisciplinary evaluation is important. In the setting of low and middle income countries, as you can see depicted in this slide, actually it is extremely important to make an initial evaluation to decide if there is no distant disease, that is, the case is potentially curable, or is distant, or the patient presents distant metastasis, which will promote that patient towards the palliative care management system. Now, during the discussions and based on what we have developed before, we try to identify ways how we can implement the existing recommendations. How do you start from the situation on the ground, and how do you improve? And actually, during the discussion, a number of phases were identified and prioritized. So the phase one in low and middle income countries proposed by the panel was to a supportive care framework to establish palliative and end-of-life care. And when whoever goes and visits a hospital in a low and middle income countries is always impressed by the large number of advanced cases or metastatic cases that are present. One has to be able to treat metastatic disease and take care of the suffering of the patient in order then to be able to develop further his capabilities to treat better in the adjuvant situation. And I think very importantly, because of lack of interest, because of various reasons, establishing palliative access to opioids, end-of-life care was extremely difficult in many limited resource countries. And we are showing in the manuscript an example of how palliative care was introduced in one country in Eastern Europe, and with how this could actually lead to the development of a nationwide palliative care system, which improved the situation for many patients. But we think that this is the first step in order to be able to deal with the amount of advanced cases that actually exists on the ground as we speak. In a second phase of implementation, we've identified the need to develop a centralized center of excellence for cancer treatment to achieve better quality care for the whole region or country. And and this is highlighted in one example that we've included in the manuscript. Many countries have these centers of excellence, and I guess, but some don't. And it is of utmost importance to be able to have a centralized center of excellence that can actually rise the standard, prove what can be done in the field of breast cancer treatment in order for the system to start getting traction and start being able to improve in a stepwise way the way it deals with his patients. The example that we've shown is an institution that was established in Ghana and that provides high quality and specialty care, and also high specialty level medical training, which is also an important need in these countries. Now, what happens is that when you have centers of excellence, once you develop those centers, they immediately become overcrowded by patients that want and need to be treated according to their diagnosis in excellence centers. And though these centers will become overcrowded, and it will be very difficult for them to deal with a large number of patients. Therefore, in a phase 3, the decentralization, the diagnosis and treatment networking was identified as a priority to improve access. And this is key to actually be able to generate a network of centers that in a coordinated way can deal with the large number of patients that we see are upcoming. So how do we do this? How do we actually provide the tools to implement these interventions into practice? And in the manuscript, we've identified that some of the work of the BHGI actually provides a number of tools that can be used in the phased implementation planning, such as the resource stratified guidelines, the implementation checklist, and the process metrics. And in my last slide, I will try to show you an example of how all this can come together in a system that can actually help you improve the situation on the ground. I mentioned earlier that we've developed checklists for most of the interventions that are needed for dealing with patients with breast cancer. And this is an example of a checklist for cytotoxic chemotherapy. I would draw your attention to the fact that we have identified the strengths, the weaknesses of each intervention. This allows us to prioritize and set the level at which each intervention is required. But on the last column on your right, you see the required resources, and this is an extensive list of what we thought was important to have available once you want to deliver cytotoxic chemotherapy. We have similar lists for radiotherapy, for surgery, for different types of chemotherapy, for different types of hormone therapy. And how can this be helpful in the phased implementation planning? Well, definitely the checklists are very useful for performing the gap analysis. During the situation analysis, you can actually do a gap assessment by comparing what is available on the ground with what the checklist will require for each of those interventions. And you can immediately identify the missing elements, and you have immediate targets that you can achieve to complete what is needed to provide safely chemotherapy, surgery, or a radiotherapy. Now, also, this checklist will actually allow you to devise a list of available interventions for which you have all the required components, which then this list will populate the resource allocation tables that I've just shown you earlier. So the resource allocation tables place each intervention and at its at the level at which the Breast Health Global Initiative believed it is important to have it for the majority of patients. So once we have a list of the interventions, this list can be populated for stage 1, stage 2, locally advanced, metastatic, and then at each level, the next question is then how many patients have access to a certain intervention. And then you can assess the level of completeness or readiness of the system to provide each intervention at each level. So this process can actually lead from analyzing the situation to actually identifying immediate targets for improvement in order to be able to go in an incremental way from one phase to the other. And I will stop here, and I will turn it over to Dr. Anderson to continue the discussion. You're muted.
I'd like to thank Dr. Anu for having provided that excellent presentation, and Dr. Ginsberg as well. What I'd like to do in this last summary is to address the systems approach. We've heard about early diagnosis, we've heard about treatment, but it needs to be networked together in a functional system that allows this to go forward. The Breast Health Global Initiative is one of the partners of Breast Cancer Initiative 2.5, BCI 2.5. This is a coalition of organizations who are focused on addressing breast cancer in limited resource environments. A key point is that we don't just mirror in other regions of the world in limited resource environments what is done in high-income countries. I'm going to provide a brief example of guidelines for mammographic screening in the United States. It was mammographic screening that is recommended for early diagnosis in our country, and the American Cancer Society has been modifying them to make them appropriate for our existing systems. They recommend starting mammograms at age 45, going actually to every 2 years at age 55, discontinuing mammographic screening at 10 years. But an important point that they made that I think was not necessarily correctly understood, they said clinical breast exam is not recommended for breast cancer screening, which was misinterpreted as that means clinical breast exam is not a useful tool. Well, actually, there are major limitations in considering these guideline applications, even in our own country. First of all, it assumes when we make these assertions that every woman is having access to mammograms every 1 to 2 years within the targeted age groups. When they recommend clinical breast exam not be used for screening, that does not reflect the critical aspect that doing a breast exam is a fundamental tool, and that you really couldn't do breast surgery if you can't do a clinical breast exam. And it also provides no guidance for women under the age of 45. And since we also have been suggesting that clinical breast exam and mammographic screening are and self-exam, that these tools have all these limitations, it actually overlooks the fact that if we just followed those guidelines and did not consider clinical practice, we would be telling all women under the age of 45, essentially, you're on your own, because we're not going to do an exam, we're not telling you to do self-exam, and that actually is not a correct interpretation of the data. The Canadian trials for mammographic screening are often identified as the trial that did not show a mortality benefit to mammographic screening. And they use this as evidence for undermining the assertion that mammographic screening works. Here is the overlap of the patients who are randomized to mammographic screening versus clinical evaluation. No differences in outcome. Now, the other major trials did not show this, and this was often used as a point of criticism of the Canadians, indicating that perhaps they don't know how to do a mammogram. That would be a misinterpretation. Actually, when you look at the Canadian data, what you can see is that in the control arm, those who were not put into mammographic screening, the median tumor size was still 2 centimeters, and that persisted throughout the study. Actually, a 2 centimeter detection is a very fine outcome. So the question is not whether the Canadians could do mammographic screening. The question is, what were they doing in the control arm that in fact allowed them to find the cancers earlier without using the mammographic screening? Because that would be the approach that would make most sense for low and middle income countries. Similarly, we have criticisms of breast self-exam. In breast self-exam, we had in the past encouraged women to screen themselves every month. And the Shanghai trial was what was used to say, oh, let's not do that anymore. Because in Shanghai, where women were randomized to training in breast self-exam versus self-detection on their own without the training, they saw no differences in outcome, similar to what we saw in the Canadian trial. But when you look at what happened in these women in Shanghai, actually 41% had tumors smaller than 2 centimeters that they were finding on their own without having undergone instruction. So in fact, the Chinese women were quite good at finding the tumors without specific education. Thus, what the Shanghai trial showed was not that self-exam didn't work. What it showed was that training in self-exam was the part that wasn't needed, especially in this context where the women were already good at finding them on themselves. Now, the Peru example that Dr. Ginsberg referred to earlier is an example of how early detection is an important issue. In a cross-sectional study in the northern region of Peru, all women who came in with a new diagnosis were surveyed to find out what happened prior to the time that they were diagnosed. And there were 2 outcomes that were looked at. One was delay in the system. Who did it take less than 90 days from initial symptoms to diagnosis versus who took longer than 90 days. And they also looked at stage at outcome. And what you can see on this graph, at the figure at the bottom, was the delay was 407 days from the initial onset to the initiation of treatment, more than a year. And that the delays were both on the patient side when they initially presented, but even more so on the health system side. Now, the point that I want to acknowledge here is that 93% of these cancers were detected by the woman. So to say that self-exam doesn't work overlooks the fact that in most of the world, it is the woman who is finding the cancer. And therefore, we need to use that tool in the most effective way. The median delay was 407 days, but of great interest, when women said that they had previously undergone a clinical breast exam. So this is not the exam where the cancer was diagnosed, but at some time in the past, when they had a clinical exam before, this decreased the delay. Fewer women experienced delay longer than 90 days. And they presented actually at earlier stage of diagnosis. So the point here is we don't want to look at these tests in a narrow way. We need to look at it in a health systems way. And we need to understand that when we do clinical exam, there is an educational component to this, where we're helping women understand what it is that we're looking for. And indeed, that in this study, the clinical breast exam in the past benefit persisted even in multivariate analysis when controlling for insurance and socioeconomic status. The Tanzania report is also something that Dr. Ginsberg talked about, and it really gets into how we have to think from a healthcare systems perspective. In this report, one of the points, this is available for downloading from the Breast Health Global Initiative portal, the pyramidal system through which cancers are managed in Tanzania, there is an initial point at the primary healthcare clinics where the patient is initially seen. That's where she would either report having a lump or whether a clinical breast exam were performed. Women are then referred to higher level centers. When we did the analysis, we found that needle biopsy was not available until level 4. This is a problem. That means that in theory, the woman would have to go through at least 3 referrals before a tissue sampling was possible. And that is a fundamental outcome. It is typically said when people say breast cancer is different in Africa, they'll say, well, there are not so many cancers that are found, but gosh, they're advanced at the point at which you find them. And then we rapidly in our part of the world say, well, that must be a biological difference. It must be different genetics. And what we are overlooking is this is a healthcare systems issue. The system actually it filters women so that only the most miserable will make it through to the point of diagnosis. This is most certainly not unique to Tanzania. This happens throughout the world, but it points out that when we think systematically, we need to centralize, especially in cancer, for certain services in order to improve quality. And so the national cancer centers are a major driver. This was recognized in the very first Global Summit in 2002, that centers of excellence are fundamental. But at the other end, we need systems that permit decentralization. We need to be able to do certain services at lower levels within that pyramid in order to improve access. And it is this balance between centralization and decentralization that makes the cancer management systems work. And so within the context of cancer, we have to realize that we should not be looking at cancer in an isolated way. We need to be thinking about our healthcare systems in an integrated way, in which we ask, what are the common resources that are needed, not just for the management of cancer, but the management of women's health or the management of healthcare system, healthcare overall. Because in fact, much of the infrastructure that is needed for cancer management is shared with other non-communicable diseases to manage the cardiovascular disease, the lung disease, the diabetes. And it is looking at this systematically and in an integrated way where we have the potential to improve outcome. So at this point, I would like to go to questions. And I please ask you to note you are welcome to voice your questions on these, and we will go through them individually. The first question comes from Dr. Atsul. This came up, Dr. Ginsberg, during your presentation. And Dr. Atsul asked, were all of the case studies that you showed involving government ministries of health in their respective countries?
Well, thank you very much for that question. It's a great question. I believe they all were. I have to just do a little mental check, but I believe they were all involving government ministries of health. Yes.
And what I add to that point is that we again have to get out of our silos. And those of us in the academic community and medical community tend to think of our world as the world, when in fact, it is an integration of the clinical community, the policymakers, and the third group is the advocacy community and the NGOs. And it's by the synergy among all of these that are necessary. The point I think that this question is getting to is that when we don't bring the governments or ministries of health into the projects, it is very difficult for them to continue. Sustainability depends upon in-country resources, and that comes from the healthcare system, not from those of us coming from elsewhere and on the outside. Dr. Ginsberg?
Yes. Absolutely, and actually in the paper we do address this, and I'm sorry I didn't elaborate. The role of civil society, the role of universities, et cetera, South-South collaborations, et cetera, but ultimately you want to be working even in collaboration with a government in order to make sure that what you're working on will be seen and potentially adopted. But not every situation is the same, and sometimes you have to do that basic work first to prove something, perhaps with a civil society organization, and then reflect that back to your ministry colleagues to be able to take it forward. Yeah.
Dr. Enyu, I'm wondering if you could comment from your perspective. You and I first met in 2002, a while ago now, and back in the Breast Health Global Initiative. I look older and you don't. I don't quite know how that works, but you were in CUGH, Romania, and you really helped me understand a lot about the limitations of the system and the integration that was needed for healthcare systems. You've now moved to a different system in Switzerland. Could you tell us a bit about how you see the integration with governments and ministries of health within practices that you've had or in other environments in which you've participated or done research?
Thank you very much for that question. Actually, I think it is a very complex situation, and it has to do with all the will that you showed that has to turn into the right direction. From many years in trying to influence policymakers in Romania, I have understood that actually we need to be able to offer them solutions. Dealing with cancer is not an easy task, as we all know, and health providers and politicians mainly are not better than us in knowing the solutions. I guess it's a mixed effort that needs to be done. First, you need to make them understand that there is a solution. If we continue to go and say, well, you know, breast cancer or cancer in general is so difficult and there's no solution, we cannot eat the big elephant in the room, then we will not very much go further. So I guess we have to dismantle this big elephant into smaller things and try to concentrate on what can be done, and it is our role, I think, as specialists perhaps in the field, to point to the right solution. Now, I make a liaison to your comment, Dr. Ginsberg, about the civil society, and I guess this is extremely important. You know, you can try to solve the situation from top down, or you can try the other way around. And I think the civil societies are extremely important in highlighting the need for change, identifying priorities that exist, and that even us, as Ben was saying, you know, we live in our ivory tower sometimes, and we don't know all the problems that our patients have. And so it is the patient advocates and the civil societies that bring those items to us. So in the end, I think, you know, we talk about collaboration and trying to bring forward everyone to make an effort. It's not happening always like that. I think it's bits and pieces that everyone can do, and actually try to put the act together to actually make the wheel turning into the right direction.
So I think that these are really important points about the integration of these different communities to make them go forward. A point that we often overlook is that when we come from a community of, whether it be a clinical community or a policymaker community or an advocacy community, we each speak our own language, and we come at it from a different perspective. And that's a real challenge. It's a Tower of Babel, if you will, in terms of how to make this work. Because the advocacy community, I think of them as a critical component. They are the drivers. They are the ones that influence the policymakers, certainly more so than the medical community. But it's tremendously important that they be well informed about what the interventions are. And so the mammographic screening debacle that we've had now for a better part of a decade, do you start at 40, do you start at 50? And these yes-no scenarios misses the more nuanced aspects that need to be done. One of the areas in which the Breast Health Global Initiative has worked with other groups within the BCI 2.5 group is the creation of knowledge summaries. These knowledge summaries provide summaries of what's the biological and clinical information, what are the policies that go along with this, and how do we understand this in a way, the goal of these being like a Rosetta Stone, so that everyone is reading from the same framework to understand where it is that we need to go. One of the questions that was asked is, how can we join the Breast Health Global Initiative? The Breast Health Global Initiative is actually just a very small group. We are trying to be catalytic. And so it's the bringing together of multiple stakeholders that makes this possible. Breast Cancer Initiative 2.5 is one of these activities in which we participate. And I recommend that you go to the web portal to examine that and see what might be of interest and available to you. I also want to raise the point in this context of phased implementation. What we've been talking about is that you need to build systems in a stepwise segmental fashion so that each step is manageable. And as opposed to going from no screening to mammographic screening and missing the parts in the middle, those steps are very important. Equally important is measuring outcome. if we do not measure outcome as we make implementation, it will not be possible to note whether our intervention made a difference or did not make a difference. And so the arena of implementation science, implementation research is absolutely essential in what it is that we do. There is a new group forming called the Coalition for Implementation Research in Global Oncology. And this group is looking at how can we bring together research in ways that are building healthcare systems in meaningful ways and that are not just addressing what we think is interesting if we're coming from the academic community or high-income country, but is actually addressing the needs of people within the countries in which the need is the greatest. And so understanding how healthcare systems can evolve is really an essential element of what it is that we can do. And we believe that the research and measurement issues are the driver that make this all possible. Dr. Gutterman has asked a question, which is, are there strategies that have been developed for cancer control in low and middle income countries that should or have impacted on high income countries? I think that is just a fabulous question. Actually, I'd like to open it. I have my thoughts, but I talk too much. Dr. Ginsberg, do you have some any examples that you're thinking of?
Well, what a great question. So off the top of my head, of course, I'm drawing a complete blank. But yes, there are examples where interventions that were either initiated, innovations in a lower middle income country, have made their way absolutely through what some used to call reverse, don't like that word. It's frugal innovation that is useful in a high income country setting. And there's a number of these actually in surgery, which I would pitch back to Dr. Anderson, but there's some well-known examples in surgery. One thing I would mention is the use of digital health systems, which may not be as exciting as saying a particular treatment or particular whatever. Digital health systems and mHealth, for example, are making their way into healthcare service delivery in many settings, Kenya being a good example with HIV care and also other East African countries and other places in the world using mHealth. The only thing I would mention there is sometimes I find that I have actually better service and better broadband connection and better mobile internet access in rural Bangladesh than I do in urban Toronto. So sometimes, you know, we have to be very open-minded about what's feasible. And people say, well, I don't get good reception here. It's like, yeah, trust me on this. You know, you've got this incredible community of young, brilliant IT developers working with health systems experts on this task.
So I can think of one example that is evolving right now. And so making a diagnosis of breast cancer, one of the things that we first saw when we went to Ghana back in 2004 was that surgical pathology was greatly limited. And it was because it had not been emphasized in the healthcare system that was mostly focused on trauma and infectious disease. And so how to do pathology is an essential element. The American Society for Clinical Pathology, Dan Milner, has been a major leader in this area. And one of the questions is for breast cancer and the great majority of cancers, immunohistochemistry is how we measure our tumor markers, estrogen receptor, progesterone receptor, HER2 new oncogene. Immunohistochemistry is hard to do in every hospital. It involves antibodies. The methodology is tricky and fickle, shall we say. Well, there's new work going on using PCR in a very affordable way that allows measurement of these tumor markers. And this is being tested in low and middle income country environments. And it turns out that it's very affordable, it's very practical, and it's based upon the same technology that has been used for TB and these other areas. I have wondered in my own practice, when will it be that we actually transition to the point of using PCR rather than struggling with immunohistochemistry, which is a perpetual challenge. So we have the opportunity to learn about leapfrog technology or new pieces that really will make this very effective. Dr. Enyu, do you have any thoughts about resources that in treatment that can be brought to bear?
Well, I mean, I would say that, as you know, many times when you go to a different country, you go there to give a lecture, and actually you learn more from the locals than you actually go there and try to teach them. So the ability to actually develop solutions, local solutions for problems that do not have a simple solution based on resources, is something that it's really struck me as a thing that it's reverse engineering, as Ophira was saying. I think this kind of transfer of information and solutions can be very important. I don't have a direct example for treatment intervention that can be used necessarily in an innovative way, but I was somehow surprised to see here in Switzerland that actually people, for instance, use the visual inspection with acetic acid for cervical lesions in a country that has access to everything. So this is just, when in simple interventions that prove their efficacy are there, people are ready to use them and use that, of course, in conjunction with all the other things. But making the best use of what is available, I think this is the lesson that we've tried to actually to understand and to teach through the BHGI, and this is an important lesson that we all need to learn how to apply.
In fact, not to plug something else I'm involved in, but ASCO, as part of the ASCO Global Health webinars shortly, there will be a session on exactly this, making the most use of limited resources in oncology in general, not just on breast cancer. So we'll be discussing that.
So I would include human papillomavirus testing being used in place of the pap smear. That my understanding from the gynecology community is that the pap smear is really on its way out, but we haven't fully, at least in the US, we have not fully incorporated this into our systems yet. So I really agree with you. This reverse engineering, we sort of forget reverse, in which there is no reverse here. This is an integrated approach. I do want to make, as a final point before we run out of time, I think it's very important in examining these healthcare systems that we all should be entering these approaches as from the perspective of being a student rather than a teacher. And I find every time I go to a new country, a new environment, and I learn more about what they're doing, I find things that are meaningful and helpful to me. But included with this is the understanding of perspective of prioritization. We always have to remember that our priorities may well not be the priorities for others. In particular, while in the US and in Canada and in Western Europe, the academic community thinks about research as the most important part that we do. And what I've been learning from African colleagues in their environment is this is not necessarily a shared view. That from the point of view of healthcare systems, it's actually the development of these systems. It's health systems strengthening that is most important in that environment. And so if healthcare systems strengthening and capacity building, if that's what is important to people in country, and we're thinking about research, that means we must think from an implementation research perspective, how do I implement ways that are specifically translatable to health system strengthening? And that's how I believe we're going to be moving forward together. With that, we're actually at the end of our hour, and I would like to again thank Dr. Ophira Ginsberg and Dr. Alex Enyu for this very, very informative discussion. I learn something from you each time we meet. Thank you very much, and thank you so much to CUGH for hosting us in this discussion today. Have a great day.